Go.
My name is Adeola Obayanju. This is a poster for my capstone. This is the presentation for my capstone. My capstone is on infection prevention after chemotherapy. That is infection prevention during neutropenia or neutropenic period. First of all, I would like to say a big thank you to my counselor and my instructor, Dr. Barbara Satel, for all the things she has done to make this project a success and for all her support and encouragement. Dr. Barbara, thank you. So I'm going to do a brief presentation of this project. I'm just going to go over the headings. I'm going to talk about the background and the problem statements. I'm going to talk about the purpose, the goal and objective, the theoretical framework, the literature review, the plan, the evaluation, and the future implication of the project, and the conclusion. So I'm going to start with the background. I work in Robert Johnson Hospital in the oncology unit, and all my observation is we've been having issues with recurrent readmission, increased length of stay due to avoidable infection after chemotherapy. And what chemotherapy does is destroy both the good and bad cells in the body. So when the cells are destroyed, the white cells are destroyed, it leads to a low count of white cells in the body, which is called neutropenia. And during the neutropenic period, patients are at higher risk for infection. And what this means is when you have infection, it increases the length of stay in the hospital, it increases the cost of health care because you have to spend so much more to cure the infection, and increases mortality, morbidity, and it reduces patient quality of care. Another thing is Medicare and Medicaid now have a policy of withholding reimbursement for never events, and preventable infections are one of the never events. So my purpose is to organize a workshop, which I did at Robert Johnson Hospital in the oncology unit, where knowledge and skill that are needed for positive patient outcome are provided for the oncology nurses in order to be able to provide the quality care that is required of us as a teaching hospital. My goals are: 1, to ensure safe and quality care for all my cancer patients, to reduce the rate of readmission and length of stay in the hospital, to reduce the staggering healthcare cost, to reduce mortality, to ensure positive outcome, because when we reduce infection, we have positive outcome, because the patients are going to be happy, they're going to live on time, and everybody's going to be happy too. And my objectives are, at the end of this workshop, the participants, which are nurses, will have the needed knowledge and skill to perform a complete assessment of patients that are at risk for neutropenia and infection. Because once you know a patient that are at risk and you're able to be proactive in your practice, you'll be able to prevent infection. Another thing will be to identify the strategy to support the core principle of patients and families-centered care relating to infection prevention. What this is trying to say is because we should all work as a team together, the family, the patient, and the healthcare provider. So we should be able to teach them, the family member and the patient, what needs to be done in order to prevent infection, because the family member, they come in, they bring food, they touch the patient, they have contact. So if they don't wash their hand, if they bring foods that they're not supposed to bring, like fruits when white counts are low, then this is going to increase infection. So we need to let the patient and the family know. So these are all the objectives. And another one is to, by the end of the workshop, I want the participant, which are nurses, to be able to do a proper hand washing, because we found out that most people, even doctors, they don't wash their hand properly. And when you do this, you transfer infection from one patient to the other, and it's going to increase the rate of infection. So we want to be sure everybody is compliant with hand washing. When I say hand washing, I mean proper hand washing technique. And another big thing is chemotherapy are given most of the time through central line. And the central line, unfortunately, is another area of infection for patients, because these central lines are not being properly managed. Some people, when they draw blood, they don't change the cap, and when you leave the cap with the blood, that's a sort of infection right there, because the bacteria are going to be feeding on the blood. And when the dressings are soiled, you're supposed to change, but people still leave them there. And the protocol says every central line dressing has to be changed within 7 days. But unfortunately, we still find some going beyond 7 days. So all this need to be taught to the nurses. And the patient, to become, when the patient are aware, they're going to pass it on to the nurse and say, hey, I've not had my central line dressing changed. So when we do all this, so infection rates will be reduced. So I'm going to go briefly over the theoretical framework. What I did was I picked on Bandura and Malcolm. Those theory dealt on adult learning. What Bandura is trying to say is certification, which is the same thing as proficient. It's just talking about if one is proficient, then one will be able to do the right thing, one will be able to teach the right thing. But if you're not proficient, you don't teach what you don't know, and you don't do what you don't even know. So the other one, Malcolm X, all is just trying to say about motivation, what motivates people to learn. So, and there are different things that motivate people to learn: when you respect people, when you make sure your attention is goal-oriented, when you make sure that people are bringing their life experiences, and you have to recognize that, because everybody comes with different background and different experiences. So you have to be able to understand that before you can teach people. So those are the things. So, and I made sure that I incorporate all this into the workshop, because when people are proficient, so when I'm proficient, I'm teaching somebody who's proficient, I'm making them proficient, then everybody's going to be able to do the right thing. And when I realize that people need to be respected, we have to be practical in teaching them, then people are going to be able to learn. But one thing I find out according to the literature is no single learning style is better than the other, but we just need a combination of all of them. So literature review, I'm going to go over that one briefly too. Literature review, I did extensive literature review on so many of the topics. I did on neutropenia, I did on antibiotic therapy, and evidence practice. What I found out was literature has proven and has shown that during the neutropenic period, patients are highly at risk for infection. And again, antibiotic therapy, what that one is saying is when antibiotic therapy is initiated early enough, I mean by being proactive, it prevents infection. It goes a long way to reduce infection rate. It goes a long way to reduce the length of stay. It goes a long way to reduce the cost of healthcare. And another thing is evidence-based. What I found out that everything that we're teaching here is evidence-based. It is proven that if you do antibiotic on time, if you don't put catheter on people that don't need it, if you do central line change, all these are evidence-based. They are going to reduce infection. The other literature that I did was on central line. I did on urinary catheter, I did on gaming, and I did on simulation, and I did on learning theory, which I already spoke about. What this is trying to say is all the literatures have shown that central line is a source of infection, and when you don't manage very well, then you're going to create an avenue for infection to get into the patient, and this could lead to sepsis. And when people are septic, then they could die from it. So people don't survive it, and apart from that, it's going to cost so much to cure those people, and literature has proven that. And again, the gaming and simulation was not trying to say even game, it's just fun, but it has shown, literature has shown that when you do game in teaching people, even though they're having fun, then they retain more. And simulation too, so that's what it's all trying to ban. the learning style is just saying, well, literature has proven that no learning style is better than the other, that the combination of all of them goes a long way to make an effective teaching on people. So the plan, what I did was we did the workshop in the conference room of Robert Johnson Hospital Oncology Unit. And with the help of the nurse educator, the head nurse, and the unit director, we were able to divide the session into two of 90 minutes each, because we want to be able to have the maximum number of participants. And we don't want patient care to suffer if we have everybody move into the conference room to do the teaching. So what we did, we did a two session. So while one group is attending the session, the other groups are taking care of the patients, and the floor is adequately covered. So we did. It was kind of an interactive session. People were asking questions. We were talking like kind of discussion. So at least we know what people need to know, and what they already knew, and what they need to know. And they too were able to acquire more knowledge during that. And questions were being asked, so we made some clarifications and correction when needed. And we did that. We did simulation. We did gaming. We incorporated all this. Everybody had fun, and at least we were able to impart knowledge. And we were doing while the session was going on. We were asking questions, because we were doing according to the objective, to make sure the objectives are fulfilled. We were asking questions, and people were answering the questions, and we made sure that the corrections are made, and gave them positive feedback when necessary, and when things need to be corrected, so we correct them. So we did those ones, and there was light refreshment. Everybody was happy, and we were able to achieve the goal. We were able to use audiovisual aid, which were provided, posters, self-learning packets. All these were all provided. And another big thanks to the IT department, who were able to assist us bring all the equipment that we needed, so to make it a success. And evaluation, I was able to evaluate the project. Like I said, questions were being asked while the session is going on, so people were answering questions, so we were able to know what the areas they were lacking and the area that they need to improve upon. We were able to do that. And we did hand washing. Like I said, hand washing and central line dressing chain, they are biggies. So these are real two big sorts of infection in the hospital. So we made sure that we demonstrated to the participants how to do proper hand washing by scrubbing, doing it for at least 30 seconds. We did those things, and we made sure that they demonstrated. So at least we were able to evaluate them that they were doing the right thing. And again, the central line too, we had central line dressing validation list, which we were able to check, because myself, the head nurse, the unit director, and the unit educator were able to observe them. So we checked them to make sure they're doing the right thing. So we were able to do. And again, there was a questionnaire about the workshop itself. So the questionnaire was on the content, the learning style, the teaching style, the settings, or all those things. So we were able to know if people were able to achieve, or maybe if we were able to achieve our goal and objective. And so we did that. And at least we were able to, through the evaluation, I saw that we were able to achieve the objective that I already set out to achieve. For future implication and conclusion, what I was just trying to say is the cost of infection prevention might be a little bit high to us, but if you compare that cost to the cost of curing infection, you find that it's kind of minimal. So what we need to do is trying to prevent infection. When we prevent infection, we'll be able, because we reduce the length of stay, so the bed could be used by another patient, which is more money for the hospital. Then when patients stay too much in the hospital, it's a lot of money. Most of them don't pay, so the hospital has to bear the burden. And the health care cost too is staggering now. It's becoming unbearable for everybody. So we need to look for a way to reduce this. And we know by reducing infection, we're going to reduce health care costs. We're going to improve upon quality, because quality is what everybody's getting for now, because we want everybody to be happy, we want the patient to be happy, because the center of everything is the patient. So we want to be able to provide quality care for them, and by reducing infection, we're going to be able to do that. So my conclusion is the upfront cost of infection prevention are small when compared to the cost of treatment of acquired infection. And we can all do this through good management of central line, urinary catheter. People that don't need urinary catheter, we make sure we don't put them in. And once we put them in, we make sure we reduce them at the earliest possible time, get them out of them so they don't get infection. We make sure we do good perennial hygiene. We make sure we do good initiation of antibiotic therapy, because when you start antibiotic therapy on time, by being proactive, then you reduce infection. And by so doing, everybody's happy. Cost of healthcare will go down. Length of stay will be reduced. Patient quality care will be increased, and patient satisfaction too will be increased, and then everybody will be happy. So, and that's the conclusion of the whole thing. And once again, just want to thank everybody that contributed to this project. And once again, I want to thank Dr. Barbara for your contribution and support. And once again, I would like to dedicate the project to all cancer patients.